Hi there. I just wanted to reinforce some concepts as it relates to the intervertebral disc, generally throughout the spine. Of course, we talk about it in different segments, referring to the lumbar region, the thoracic, and the cervical regions. But again, just some ideas to keep in mind as far as the disc goes and how we look at disc pathology in the clinic. So one place to start, of course, is with the anatomy of the region. So this, of course, is showing you the lumbar segments. But you can see here, each lumbar vertebrae sitting on top of the one below it. And in between the vertebral bodies, which is the bony mass of the vertebrae, of course, you do have your intervertebral disc, and that's partly where they do get their name. So the intervertebral disc does play a big role. It does occupy a great amount of space within this spinal region. And so that's going to have implications for pathology. And so you can kind of see here, the discs are represented here, the L1, 2, L2, 3, L3, 4, and L4, 5 discs. And then if you look at each of these vertebrae kind of segmentally, you can see a general increase in size as we progress from L1 to L5, primarily in that vertebral body portion of the vertebrae. And so that implies that the discs that sit in between these respective vertebrae, they're going to also progressively increase in size as well. So generally, when we talk about the intervertebral disc, there's two main components of the disc that you're probably familiar with. However, there's a third portion that we do need to consider as well. So the two main portions of the disc are the nucleus pulposus and the annulus fibrosus. And so nucleus pulposus is a little bit more gelatinous in nature, does have a higher water content. It's kind of the central part of that intervertebral disc. And then the outer layers are kind of an arrangement of collagen fibers in a concentric pattern, and that we refer to as the annulus fibrosus, and that provides a lot of the structure and form to these intervertebral discs. Now, because the discs have a close association with the vertebral bodies, both superior and inferior to each respective disc, there's also an area of interface between disc material and bony material of the vertebral body. And so we refer to that as the vertebral end plate. Now, this is significant clinically because most often you've heard of a disc herniation as a bulging or an extrusion of material, nucleus material through the annulus fibrosus. However, that nuclear material can also become dislodged or herniated in a superior-inferior fashion, and that occurs into the vertebral body, specifically into the vertebral end plates. And so this, when you do see a projection that way, you may see it on imaging. However, if a patient does present with that projection into the vertebral end plate is referred to as a Schmerl's node, and that can be symptomatic as well and cause pain in the referral patterns of these discs. Now, when we talk about it biomechanically, function-wise, one of the primary roles of the intervertebral disc is to provide a cushioning effect or a dissipation of force type effect throughout the spine. So that's visually depicted for you here, where this large red arrow represents some type of load, axial load through the spine. That could come from something as simple as sitting in a chair. Could definitely come from activities like walking, carrying heavy objects, and of course, more traumatic loads as well. The point being, though, that every force that travels through one of the four extremities eventually makes its way into the spine, and that force has to be dissipated by the disc. So these smaller red arrows give you a representation of how that force is potentially distributed through both the nucleus pulposus and the annulus fibrosus. Now, in a normal, healthy individual, that this is occurring quite regularly. It's occurring right now as you're listening to this within your own spine and your own disc. And it's usually not an issue. It's not a problem because the disc is able to handle that type of force. But if there is an over exertion of force or an excessive amount of force that overloads the disc and the force dissipating ability of a disc, that can cause a injury to the disc material. And then depending on the severity of both the force um, and the injury that's at play, the trauma, that could lead to more significant disc disruption and disease as well. So that's something that we need to consider when we're evaluating patients is what was that mechanism of injury, and really trying to understand how potentially a disc, if we suspect that's the issue, how it may have been overloaded. So when we do have injury to a disc, we usually think about it in terms of two different types of disc disease, and we refer to them as primary disc disease and secondary disc disease. You may also see this used in the clinic and referred to as an acute disc type injury versus a chronic disc type injury. So the primary disc disease or acute disc, that usually results from an overload of force, some type of excessive trauma to the region that essentially overloads the resistance capabilities of the disc material. Versus a secondary disc tends to occur, may have started as a primary disc disease at a younger age in that individual, but over time there now becomes subtle changes within the disc, and so that it increases its, or I should say, the threshold for activation of symptoms decreases, and so now smaller forces tend to have more of a impact and lead to potential pain or other symptoms. So when we think about these two, we can divide it into some general manifestations or categories. So primary disc disease tends to occur in younger individuals or those with healthier spines. Now, that doesn't mean an older individual can't have primary disc disease. They may if they've had a relatively um, spinal or disc related history of injury. However, it does tend to happen in younger individuals. The symptoms originate within the disc itself, and that disc tends to be that primary symptom generator. In these individuals, the disc tends to be relatively thick. It is hydrated quite well. And so the problem really occurs from a leakage of fluid or excessive movement of that nucleus pulposus type material. And that can essentially cause pain. There is pain receptors within the disc. And so it would be an activation of those pain receptors. Now, compare this to a secondary disc disease. This tends to happen in older individuals or those with unhealthy spines. Now, once again, that being said, a young individual may have secondary disc disease depending on what their spine and their discs have already been through. Now, with this, the symptoms can originate within the disc, but usually if it does, it's because of the degenerative processes within the disc. But oftentimes, the symptoms can actually originate in other structures as well. What tends to happen is these discs tend to be more worn out, have poorer hydration, and hence they're unable to really distribute that load, such as that diagram previously demonstrated. So now the problem is that, we still want to perform function. Your patients are still going to want to, and they are going to perform various functions. So now if the disc has degenerated to the point where it has an inability to distribute that load's still going somewhere. So usually what happens is it transfers to other structures in the area. Some of the primary structures are the zygapophyseal or the facet joints in the region. However, it can go into other structures and the ligaments of the area, the muscles have to play a bigger role. But the point is that the origin of symptoms may not come directly from that disc anymore, but now there's more involvement of greater anatomy and pathology of the region. So when we look at the specifics of nucleus pulposus and annulus fibrosis, so this does break down the information as far as what you expect to see histologically within both types of material or disc material. Now, the main thing to understand here for our purposes is the amount of water content. So again, in a primary disc, the water content tends to be high in both the nucleus pulposus and the annulus fibrosis. As that disc degenerates, the water content naturally decreases, and that is partly what contributes to its inability to resist certain types of load. The other thing to consider as well is there tends to be a little bit more type 1, type 2 collagen in a primary disc, as well as elastin, which again all contributes to the ability for that disc to adapt to stresses that are placed on it. Versus when a disc degenerates, it tends to increase the amount of type 3 collagen that's present, as well as leads to general flattening out or thinning of both the vertebral end plate and the disc itself. So these degenerative changes are important to consider because they are going to manifest in different ways in the patient that's coming to see you. So this gives you a visual representation of how a disc potentially can progress from that generally young, healthy disc to a older, unhealthy disc. And so in this first diagram here on the very left of this slide, this is a generally a healthy disc for the most part. It's everything's intact. It's got a good center here, nucleus pulposus. You can see some of these concentric rings of the annulus fibrosus. Now, in this one region right here that I'm circling with the arrow, right there, you can see there is a disruption in the amount of the material that's there. So this has likely been a disc that has undergone some type of overload of force, and now it's caused damage in one part of the disc. Now, this specifically is referred to as an internal disc disruption because it's contained completely within the disc itself, and there's no type of bulging or herniation of any kind. But because there are pain receptors within the disc, this can cause pain within that individual. And so this is a classic example of primary disc disease. Now, keep in mind, the water content is higher in these discs, these primary discs. So imagine if there's excessive amount of movement of structure, because with the compromise, some of that form or structure that the annulus fibrosus provided that is compromised. So now the nucleus pulposus has the ability to shift around and move a little bit. That in itself wouldn't be an issue. However, there are pain receptors here, and that can trigger a pain response. Now, imagine this person went to physical therapy, they did improve, or maybe they didn't improve. The point is, time now has gone on. And so, what happens over time is that because this minor disc disruption now alters the biomechanical abilities of this disc to resist load, that load now is distributed in uneven patterns versus what it was designed to do. And so what happens now is that triggers a sense of degeneration within the disc. So you can see this disc here, there's a lot more involvement, especially here in the nucleus pulposus. And you can see that there's more areas that are disrupted and do lead to potential pathological presentation. If we continue the timeline down, you can see this disc is even further degenerated. And so imagine this now disc getting to the point where it's completely thinned out, very little water, degenerated. The fibers are not robust at all, but they're very, again, thinned out. Imagine the disc like a tire that's become completely flattened. And so this is essentially what could happen. So this final diagram here is a classic case of secondary disc disease. Now, again, the person is still performing function or wants to perform function. So imagine this primary disc handling mechanical force and load versus the secondary disc. So the secondary disc is not equipped at all to handle that load. So once again, that load goes elsewhere. Oftentimes it's the facet joints and the other structures in the region. So when we talk about clinical manifestation of primary disc, these are the terms and the definitions that we use to define them. So again, that internal disc disruption, which we just showed you a picture of that, that is the issue is self-contained within the disc. Once you start having some type of bulging, that's when you get into these other terms. So a protrusion is just some fissuring within the annulus fibrosus. However, the annulus fibrosus remains intact, as well as the posterior longitudinal ligament. But the person may have some bulging. So there is some bulging of nucleus pulposus material into those concentric layers of the annulus fibrosus. The next stage would be a prolapse. This is more severe fissuring now, where the fibers of the annulus fibrosus could be compromised. And now you have disc material bulging more towards the peripheral rim of the disc. But however, the posterior longitudinal ligament is still intact. So the disc itself, although it could be bulging into the central canal or the intervertebral foraminal space, there's still a barrier protecting disc material from extruding into those structures. That's not the case with a disc extrusion. Now the posterior longitudinal ligament has become compromised, and now nuclear material can herniate or bulge into more severely into the neighboring structures in the area. Oftentimes, the spinal cord can be involved if it is a central canal or central extrusion. If it's more of a posterior lateral corner extrusion, which is quite common in the lumbar region, then oftentimes the nerve root at that level could be impacted, and it could lead to nerve root disease. Finally, we have a sequestration, which now this is severe enough where not only is nuclear material bulging out through the annulus fibrosus, but fragments of it have broken off now and can potentially be within the spinal column. So this is the general progression of primary disc disease. Now, keep in mind, depending on the level of trauma, a patient may come see you with back pain, and they may be at any level of this primary disc disease, just depending on how severe the trauma was and how well equipped their spine and discs were to handle the resultant load. And as I mentioned before, this disc material can bulge into that vertebral end plate. So we call that a vertebral end plate fracture, also referred to as a Schmerl's node. Now, secondary disc disease, its manifestations can be a little bit more complex. So it occurs mainly in two ways. One is what we call specific low back pain, and the other is what we call non-specific low back pain. And so specific low back pain occurs in three main ways. You'll have a patient present with instability in the lumbar region. They may have a listhesis or a slippage of one vertebrae on the vertebrae adjacent to it. Or they could present with stenosis, which is a loss of foraminal space, within that central canal. Now, those are specific forms of low back pain. Non-specific low back pain has to deal with changes in movement pattern of in the case of the lumbar spine and thoracic spine, the zygapophyseal joints. And when we discuss the cervical spine, you'll see it's zygapophyseal joints and the UVJ, which will be the uncovertebral joints, which are unique to that region. So you could have a hypermobility, which is an excessive movement of one bone, one vertebrae relative to the next bone. And so this can occur due to a chronic disc irritation, secondary disc disease again, or some type of ligament capsular sprain, or even joint chondropathy. Or you could have a hypomobility, which is a decreased amount of movement resulting from movement of these joints in between these segments. And this often occurs due to either a joint capsule synovitis or degenerative joint disease, which goes hand in hand with degenerative disc disease. You can also have non-specific low back pain, which involves chemical changes. Now, this is a little bit more severe where a person has had disc disease for a longer period of time. And now it's led to histochemical changes within the tissue itself, where those thresholds for pain activation have decreased. And oftentimes these patients, even with what we consider simple movements, it could be enough to trigger quite a dramatic pain response. This is also non-specific low back pain is also where the psychosocial avenues or considerations need to be made as far as disc disease and back pain in general. So when it comes to the clinic, oftentimes, patients will present, they may present with something that's very clearly a primary disc disease, something that's very clearly a secondary disc disease. Oftentimes, it's not that clear cut, and we have to differentiate between a primary and secondary disc disease. That, and we would also have to differentiate whether the disc is even involved, or again, if it's some other structure in this region. So some of the relevant tests that will help us isolate and kind of differentially diagnose that a disc could be involved. We're going to do some provocation testing. So that's really going to be based off of our range of motion. And we're really look at straight plane range of motion. So primarily the sagittal plane and the frontal plane. The discs of the lumbar region play a primary role in resisting movement or controlling movement in those two planes, especially the sagittal plane. Some of the special tests that we potentially would use is the vertebral spring test, as well as the slump test and the straight leg raise test. I'll talk a little bit more about the straight leg raise test in just a moment. Some of our general screening tests, such as myotome, dermatome, and reflex tests, those potentially could indicate disc disease as well, due to a potential nerve root impingement or some type of nervous tissue involvement due to a herniated disc or a degenerated disc. So oftentimes we're going to look in all of our tested measures, we're looking for pain patterns or even in our history taking or what the patient's complaining of. The intervertebral discs tend to have, both what we call monosegmental innervation and polysegmental innervation. And so the nucleus pulposus material tends to be what we call monosegmentally innervated. So a lot of times if that's involved, like for example, if they have a internal disc disruption, which is a type of primary disc disease, patient will come in and you ask them to point to the pain, they'll take their thumb or their index finger and they'll place it on a specific spot on their low back. And so we call that a thumbprint pattern of pain. And that doesn't definitively mean they have internal disruption or primary disc disease, but it's a good supportive piece of evidence that that may be what's involved. Now, that being said, just a side note, the zygapophyseal joint, if you have a single level zygapophyseal joint involvement on just one side, for example, degeneration of that joint, that could also present as a thumbprint pattern of pain. So like I said, these are giving you clues, but not definitive answers. If the annulus fibrosis material is involved, then that's polysegmentally innervated. So a lot of times they'll say, you ask them to point to it, they'll take their entire hand and place the palm of their hand somewhere on their back. And so if the disc is involved, again, not definitive indicator of disc involvement, but if they do and show you that, then that's a good supportive piece of evidence that maybe the annulus fibrosis is compromised. And so that could be a little bit more severe form of primary disc disease. Versus patients that have secondary disc disease, not all of them, but oftentimes they'll have more bilateral type back pain or more global type presentation. They tend to have more radiating symptoms into the extremities. And one of the characteristic pain patterns is what we call bandwidth of pain, where you ask them to point to the pain, they kind of just show you this area across their entire low back region. And so that's the result, again, of that flattening out and degeneration of the disc and involvement of some of these other structures as well. So I just want to take a moment to just talk about the straight leg raise test, because it is an important test that is going to help us differentiate and help isolate disc issues here in the lumbar spine. So there is an associated video that you can watch to understand the procedure for this test. And the steps, of course, are indicated for you on this slide. So when it comes to the straight leg raise test, we have a couple of different possible findings, depending on if the patient has a suspected primary disc issue or a secondary disc issue. So again, the primary disc issue, it tends to be a healthier, more robust disc, more fluid content. And so there's more of a true kind of herniation type effect or a bulging type effect. Now, what tends to happen, if you look at this diagram here, you could see that if the disc does bulge out, the disc is represented by this structure here. The vertebral bodies are on either side of it. So this disc, as it does bulge out, it potentially can impact this structure here, which is the nerve root. And importantly, it can cause what we call nerve root impingement. So a patient may present with certain symptoms characteristic of that, such as neurological type signs, numbness or tingling. If it's severe enough, then maybe some motor changes, some reflex changes. So that's a clinical type presentation. Versus a secondary disc, again, that's more of the flattened out disc, more of the flat tire type disc. So this tends to be more of kind of a stagnant state where there's not an acute bulging out, but more now it's occurring more chronically. So this disc just tends to kind of be more flattened out. The amount of space in the intervertebral foramina has decreased. And so essentially the nerve root has now become pinned down by the disc. So when we perform the straight leg raise test on patients, Oftentimes, if the patient complains of any type of tension type event, which would involve, for example, when you go through the steps of the straight leg raise, they complain of pain. When you add the cervical thoracic flexion, that increases their pain. And then when you remove the tension by allowing the foot to plantar flex, then that relieves the tension. In other words, there's not as much of a pulling on the nerve root and the dural tissue. So that's a classic result on the straight leg raise test, indicating there may be a primary disc issue. Versus a secondary disc issue, again, that nerve root tends to be more pinned down. So now it's more of a compression of the nerve root and not a true tension of the nerve root. So because of that, when a patient does have the beginning of the straight leg raise test, they may have some pain with the first part, with the distal initiation and the lifting of the lower extremity, and then adding the cervical thoracic flexion that usually won't change their disc or their pain that much, because the nerve root is still pinned down, so there hasn't been any physical real movement of that. However, when we do add the plantar flexion of the ankle, now all of a sudden the area that's been chronically pinned down, such as is demonstrated in this diagram here between these two arrows, that imagine a frayed part of the nerve root. Imagine your charging wire on your phone, and over time, if you touch the same spot over and over, it becomes frayed. So imagine the nerve root is doing the same thing, but now when you plantar flex the foot, you allow that frayed portion of the nerve root to move away from the disc that's pinning it down. And so that potentially now is going to alleviate or relieve some of their symptoms. So those are some clues that you can look for on the straight leg raise test to help you, again, differentially diagnose if the patient has a potential primary or secondary disc issue. So these are the references for this short lecture. So please do reference these if you have any questions. And like always, you can reach out to me if you have any questions as well. Thank you for listening, and I hope you have a fantastic day.